everyone. This is Nayiri from Low Carb and Fasting. For those of you who are familiar with this channel or familiar with me, you will know that I'm a type 1 diabetic of 44 years now. And I'm very passionate about spreading or about raising awareness of type 1 diabetes, and particularly spreading the message of low carbohydrate diet as an effective intervention to manage type 1 diabetes and reduce risks of diabetes-related complications. Okay, so our guest today is a fellow type 1 diabetic. He's a medical doctor from the University of Queensland. He's completed his fellowship training as a radiologist. He's even won an award in radiology teaching just a few years ago. He follows the low carbohydrate diet to manage his blood sugars better. He actually holds several other qualifications, both graduate and undergraduate. Dr. Troy Stapleton, welcome to Low Carb and Fasting.
Thank you, Nayiri.
Dr. Stapleton, why don't you mention at least some of your other qualifications?
Oh, I don't. Well, I've got my medical degree and then my fellowship in radiology, which is a specialist qualifications and as a radiologist. Yeah, they're the main qualifications, I guess. I do have a role at the university teaching the medical students as well. So I'm the the radiology lead for one of the universities as well. So yeah, that's it, I guess.
Before we talk about your diagnosis, my take on radiology is that it's kind of a privileged department to work in because you are exposed to different medical conditions, right? I mean, you're seeing images of people, I don't know, with brain tumor or heart scans, or so you're exposed to different medical conditions. What do you think of that? Is that what attracted you to radiology in the first place?
Yeah, look, it's interesting, I guess. You know, I had had a number of different interests as a junior doctor. So I worked in CANS for a while, and I had a number of interests. At one stage, I was interested in ophthalmology. I was interested in pediatrics, and then in fact, we had a US doctor who came and did a locum in the hospital I was working at. So I was working at one of the regional hospitals in Queensland, and he just made such a difference to the hospital. And I was like, wow, this is actually, you know, you can really make a big difference as a radiologist. And so that's how I really became interested in it. And I've never regretted my decision to do radiology. Like it's I guess the way of describing it is that we sort of spend our day solving puzzles in some ways, in that we get a clinical history, we get given a history by the referring doctors, and they're sort of saying, you know, we have a patient with, say, abdominal pain, and then they might give us some of their symptoms, or and then we would look at the images and then try to come up with the diagnosis. So, you know, that's I guess that's what we find interesting, and what the fun part of the job is essentially solving puzzles, and you know, you can make you know, you can really help patients on their journey by making that diagnosis swiftly, by using the correct imaging to get the diagnosis, you know, to get the diagnosis right, and then the patient then can get the correct treatment. So, you know, that's essentially the role of the radiologist. We also do other, it's not all sort of interpreting the imaging. Some of it's, we might be asked by the other doctors to obtain a biopsy of a lesion that they're not sure of, and we might use sort of imaging guidance to help us, either ultrasound guided biopsy or potentially a CT guided biopsy, those sorts of things. So yeah, that's the job. And then I've worked in the public hospital system in my home state, and so I train registrars or trainees in radiology as well. So that's also really you know, a part of my job that I really love. Yeah.
Dr. Stapleton, when were you diagnosed with type 1 diabetes? You see, I don't remember life pre-diabetes because I was so young when I was diagnosed 44 years ago. So, but you were diagnosed when you were an adult, right?
Yeah, so I'm 51 now. I was 41, so it's a little bit over 10 years ago now. And yeah, I mean, it's interesting really when when I look back. So I had, with a group of my university friends, we had started doing. You can do the Noosa triathlon. It's quite a big triathlon in Australia, and you can do it as a team where you each just do one leg of the triathlon. Essentially, it's like a relay, I guess. And so I was doing the cycling leg in the team, and a friend of mine who's an orthopedic surgeon, he does the swim, and then another friend of mine who's a cardiothoracic surgeon. We all went to uni together. He would do the run. And so I had been training for that, and then, I was weighing, I've never been overweight, but I was carrying a couple of extra kilos, and I was sort of thinking, it'd be nice to drop them down. I used to weigh, I guess, around 80 kilos. And anyway, in the lead up to this training, I started dropping, a kilo a week. And I thought, this is good. It's partly the training. I had actually, interestingly, I had read a couple of books on sort of diet, and I had come to the conclusion that sugar was something that we should be limited in the diet. So I was sort of already on that sort of pathway, I guess. And so I had taken sugar out of my diet. And so I was dropping a kilo a week, and I thought, this is good. This must be that I've dropped the sugar out of my diet and all that sort of stuff. And then I, started waking up at night and having to wee every night, to pass urine every night. I thought, that's, a bit odd, but didn't think too much of it. And then, this sort of weight loss really, started to accelerate. I was sort of getting tired, and, again, was having to wake up every night to go to the toilet. And then I woke up one morning and I sort of looked at myself in the mirror, and I could see that I really started to get lean. I dropped down to about 68 kilos in the end. And then I thought, oh wow, this is like not right. And I had some people comment too, oh gee, Troy, you're looking a bit lean type thing. Anyway, I thought to myself, it couldn't be diabetes, could it? Just as a sort of couldn't be that. Anyway, interestingly, a few years prior, one of my boys, I've got 3 boys, one of my boys had been sort of toilet trained, but then he started wetting his pants, and I'd sort of worried that it could have been diabetes, and so I dipped his urine. So we had urine dipsticks in the cupboard, so I thought, I'll go and dip my urine, thinking it would be like dip my urine, no glucose in the urine, it's probably okay, and just sort of get on with, lost a bit of weight, that's all right type thing. Anyway, it came up 4+ of glucose, I think 4+ of ketones as well. So, I was like, pretty sure I had diabetes at that stage. And then I went to work hoping that, maybe the dipsticks are, not accurate, or, something like that, and then tested my blood glucose at work, because obviously I didn't have a blood glucose meter at that stage. And it was, it just read high. And so then I went to, fortunately I knew one of the endocrinologists at work, and I went and saw them, and they did a HbA1c on me. They did antibodies, and they measured my blood glucose, and they could get a number, and it was 32, and my A1C, I think my A1C, it was about 11.4 at the time, and my antibodies were through the roof, actually. They were in like the thousands. So yeah, I had a confirmed diagnosis of type 1 diabetes.
So you were in medical school then, right? Did you know much about type 1 diabetes?
I was a radiologist then. I was a radiologist then, 10 years ago, yeah, no.
So did you know much about type 1 diabetes?
Not a great deal, to be honest. Like I had done pediatrics as one of my terms. Like as a junior doctor, I had done what we call a principal house officer job as in pediatrics. So I had diagnosed a young 2-year-old boy with diabetes. So I knew a little bit about it, and I had done also some rotations as a medical registrar. So I had managed people with type 1 diabetes. But, I really didn't know a great deal about it, to be honest. Like I knew some about it, but not as much as obviously I know now. And I guess as a radiologist, my interactions with it would be, sometimes we'd be diagnosing the complications of diabetes would be mine.
Mm-hmm. We're going to talk about some of the complications of diabetes, but before we do that, what introduced me to the low carbohydrate? What introduced you to the low carbohydrate diet? Because initially the recommendations would have been, when you were first diagnosed 10 years ago, the recommendation from the Australian Diabetes Organization, whatever it's called in Australia, would have been very similar to what Diabetes UK recommended to me 10 years ago, and what was recommended by the ADA in the United States. Yeah. And it was like, eat your grains, eat 3 solid meals every single day, and take a set amount of insulin, and and to avoid hypos. An insulin dose would have been really high, much higher than what we really need. So you have to feed yourself snacks as well, so you don't drop low. Was it similar, the initial recommendation you received?
Yeah.
And then how did you come about, the low carbohydrate diet?
Yeah, no, very similar to that. So I was recommended to have 240 grams of carbohydrates a day, and that was to be 3 meals of 60 grams a day. So that's 180, and then a couple of 30-gram snacks. I was told that if I looked at my plate and it didn't have enough carbohydrates on it, then I was to add carbohydrates to that plate. So, like, for example, if I had like a meal which I might have now, which might be sort of meat and green vegetables, for example, but if I was to look at that plate and go, there's not enough carbohydrates on that plate, then I was advised, to get a bread roll or something like that to essentially bulk up the carbohydrates. So, I went back and saw the dietitian a couple of times, and my wife came along as well, and we were like trying to learn all this stuff. So, and I was absolutely committed, okay, I'm going to do this exactly by the book. Now, interestingly, I had read these books previously about, diet. So it was something I had an interest in, but more, I guess I was more against the sugar than the carbohydrates at that stage. But anyway, I guess after my diagnosis, it was a great shock to me. And I really, it was a difficult couple of months for me, I'm going to be honest. Like, it sort of plunged me into what I now recognise as quite a deep depression. It manifested as anxiety and those sorts of things, but I was depressed, and because it was just such an out of the blue diagnosis, and it's I've done a bit more reading about that as well, and when patients are diagnosed with a chronic disease, and particularly with a disease as difficult to manage as diabetes can be in terms of the constant nature of it, it is, you go through a grieving process essentially. And so I certainly feel like I went through that. But during that time, because I was having trouble sleeping, I was reading. And so I, was reading, obviously some of it sort of hopeful reading, trying to figure out where, cure, where that literature is, like how close are they to a cure, or, what are the best treatments and those sorts of things. And the more I read, low carb would pop up at times, when I was doing these sort of medical searches, and Dr. Bernstein's name popped up and those sorts of things. And so I looked at that and thought about it, and it made sense to me. And I guess it also had made sense to me a little bit just the low carbohydrate approach. I mean, because I'd read these books previously about diet, and I'd read some of the work by Gary Taubes. In fact, Gary Taubes is interesting because now I can't remember the exact date of the article, but he wrote an article in the New York Times, which was what if it's all been a big fat lie, I think. Basically, he wrote an article in the New York Times, you can search it up, but I had read that article probably about, not quite 10 years before my diagnosis. And I was so impressed by it that I'd actually printed that article out. And I was just like, wow, this is, amazing article. And I had read one of his books as well. So anyway, I'm getting off on a tangent there. But I had, low carbohydrate did resonate with me, I guess. It made sense to me that if carbohydrates obviously raise the blood sugar the fastest and the most, and that eating less of that would make sense. But at least initially I was committed that I was going to do exactly what the dietitians told me, and I was going to try and figure this stuff out. But I was reading the whole time about different things. Anyway, I kept reading, and I then went searching, and I thought, well, I'm being told that I have to, I should have 240 grams of carbohydrate a day. And I'm hearing about this low carbohydrate approach. Surely this has been, tested. Like, surely someone's done a proper clinical trial and actually tested this, if this is the advice they're giving us. And so I went looking for that, and I'm going to be honest with you, if I had found an article, a good, well-run clinical trial that compared a low-carbohydrate approach to what I was being recommended, and it had shown that the recommendations that I was being given, the higher carbohydrate approach, was a better approach, then I would have said, oh, well, it's been tested and, it won, right? But that article doesn't exist, So I, at that stage, I realised really that there's not solid evidence for the dietary advice I was being provided. And so again, I guess that really made me think, well, this low carbohydrate diet makes sense. And I remember it was actually probably almost 10 years to the day that I remember I was driving to Brisbane where my mum lives, and I was with my wife, and I said, I'm going to give this low carbohydrate approach, I'm going to give it a go. Like, I'm going to try it because it makes sense to me. And I'd read Dr. Bernstein's book by this stage. I'm going to follow, Dr. Bernstein's advice essentially on his dietary recommendations. And my wife said, oh, well, if you're doing it, I'll do it with you. And so it was really from there. And I've actually still got at that stage, I didn't have a continuous glucose monitor. I was doing the multiple daily blood tests as you did, and so I was writing it all down in a diary. And so you can see from the date that I went low carb, like, all of the numbers just changed, from going from 8s and 10s and 12s and 14s and those sorts of numbers. And I realized for some people they're not that high, but I immediately went to 5s and 6s and 6s and 5s and just plateaued. And so I would be a LADA, so that latent autoimmune diabetes of adults. So when I was diagnosed, I probably, from what I've read, often you've still got 10 or 20% of your beta cell mass remaining. Yeah, so you've got some insulin producing capacity. It's not completely wiped out. And so I was able to reduce the insulin that I was taking. So I had been on, when I was having the 240 grams of carbohydrates a day, I was on about 24, 25 units a day. And I was able to go down to 6 units a day. So, and in fact, I didn't, with a low carbohydrate meal at the time, I didn't need to bolus for that meal. I do now, like, over time, over time, beta cell mass depletes, and it gets to the point where you have to bolus for every meal, and I certainly do now. But at the time, I went from 24 down to 6 units. My average blood glucose number was 7.8. That went down to 5.5 or thereabouts, and my A1C went down. I think my first A1C post going low carb was 6.3, but that was obviously a trailing indicator. And then from then on, I've certainly predominantly been under 5.5, but in recent times, 4.8 even, so just tapered down. And this is 10 years down the track now. But obviously I've had to, well, not obviously, but I have had to increase my insulin over that 10-year period, because over that time my beta cells have obviously depleted to the point where I would have, no functional beta cells remaining. And therefore my insulin requirements have come up. But yeah, so it was quite miraculous for me. And in fact, it really helped me a lot. Not just, I guess one of the other things where it really helped me was the mental health side, because I went from someone who, I went into this deep depression and I had a lot of anxiety. And then I started seeing normal numbers and consistently normal numbers. I wasn't having hypos, so I wasn't scared of hypos anymore. I was having normal numbers all day and fairly flat blood glucose numbers. So I started to think, well, I'm not going to get the complications of diabetes if I can maintain, normal blood glucose levels, and I wasn't having hypos. And the other thing that I found is just because I was able to use a lower dose of insulin and I wasn't having hypos, I could then, return to exercise, which for me was really important. And so I just found that, I came, out of, quite a deep depression and for a while they're quite crippled with anxiety. And literally all that went away. And I just found it, miraculous. And I guess that's one of the reasons I've been happy to speak about it, is because, it helped me so much. And so I'm happy to share, I guess, my experience of it.
It's interesting that your depression went away, or the anxiety went away too, with a low carbohydrate diet. I mean, that's one of the good side effects. People forget that. Yeah. I think people don't associate mental health with fluctuating blood sugars or high blood sugars and fluctuating to make it worse. But that is one of the...
Yeah, I'm sorry to interrupt you, Nayiri. Yeah, I think Dr. Bernstein's actually published on that, because he's noted that before. I'm not sure if the fluctuating blood glucose levels, it was in self was causing the depression. I think it was more my fears about the complications of diabetes and fears of hypos and those sorts of things. So like when I was on this roller coaster blood glucose level, then obviously that, I had a reason to be anxious in some ways, because I knew that firstly, those high blood glucose levels, down the track, it increased my risk of complications, but also, the short-term fears about profound hypoglycemia leading to, even, patients can die with hypoglycemia. So that resolution of that fear and the long-term fear as well, that's really what helped me come out of the period of depression. And it was so I had 2 months post-diagnosis, and then I went low carb 2 months post-diagnosis, and then very rapidly came out of, this very, depressed period.
What I can attest to is the mood swings. I mean, if my blood sugars are stable, I'm happier, and I don't get the mood swings. But on an awful day, which thankfully are rare for me now, but hormones also, female hormones do play a role when you're approaching 50. So there are days when I just can't explain anything. I just have to sit back and just look at my horrible graph and think what a failure I am. And it has an impact on your mood, at least for that day. And then the next day, I might just decide to fast or have one meal. everything gets back to normal. So where do I start next? I mean, we are going to talk about fasting or intermittent fasting. But before we do that, you mentioned complications. Now, what are some of the diabetes-related complications that people don't think of when they are eating a high carbohydrate diet, taking unlimited amounts of insulin to cover the carbohydrates, and they are running high. They're running high pretty much all day long, high or higher.
Yes.
But they don't realize, they don't understand the complications. They think, okay, so we're kind of invincible, it's,
Yes.
I can't think too far ahead at the moment. So what are some of the complications? Because I think for type 1 diabetes, it's not any different than type 2 diabetes, similar complications.
Yeah, look, there's lots of complications, I guess. I guess for me, one of the ones that I would have feared would have been with my eyes. So obviously diabetic retinopathy would be a risk, and particularly in my line of work, I need my eyes. But, you can start at the top and work your way down. You've got an increased risk of stroke, increased risk of heart attack, chronic renal disease, peripheral vascular disease, amputations, you name it. It's a very long list of complications that I was acutely aware of with the diagnosis, and therefore anxious to avoid those complications if I could.
Mm-hmm.
Yeah, and again, during that, particularly during that post-diagnosis period, I was very worried about those, but since then I'm a lot more relaxed about them. My blood glucose is predominantly normal. I use minimal. I use sufficient insulin to keep my blood glucose in range, and I exercise regularly and try and look after my health as much as I can. Yeah.
So as a radiologist, I'm sure you do the CT scans, right? For coronary arteries. How many diabetic patients do you see? I mean, type 1 and type 2, but how many of the patients have some type of diabetes or even pre-diabetes?
Yeah, I mean, look, it's very prevalent in the community.
Yeah.
So, and it's interesting, because I have an interest in it as well. You're quite right to mention pre-diabetes. So a lot of patients will have what's called the metabolic syndrome, which is, it's actually essentially a pre-diabetic state. They're insulin resistant, but their pancreas is able to produce sufficient insulin to keep their blood glucose in range. But despite that, they've got a number of other things. So they have truncal obesity, they have high blood pressure, they have elevated triglycerides with a low HDL. They've got that sort of, little rotund tummy with skinny arms and skinny legs type thing. It's a very common body shape that you see. So we obviously see those patients. We see patients with fatty liver, and we can diagnose that on our imaging. A lot of the patients, and then of course we see a lot of the patients with type 2 diabetes, again, coronary artery disease, strokes, chronic renal disease, so, and amputations and peripheral vascular disease and infections and those sorts of things. So we see, radiology is a specialty that sees all those complications of pre-diabetes, type 1 diabetes, type 2 diabetes. So I was very aware of all the potential complications that can occur from diabetes.
Mm-hmm. People always refer to type 2 diabetes specifically as as a progressive disease, because it will get worse and worse over time, and there's nothing you can do to stop it. But people don't really look at type 1 diabetes as such. But it is uncontrolled. I have to be careful. Uncontrolled type 1 diabetes or poorly controlled type 1 diabetes can also be a progressive disease.
Yeah, well, I guess I'd make two comments on that. The first comment is that certainly we were taught that type 2 diabetes was a progressive disease, but interestingly, it's now accepted that you can at least put it into remission. I think that's probably the word that people are using. Some people say reverse, some people say put it into remission, but that's really becoming accepted now, and that's only become accepted in the last 10 years, that it's actually possible to put type 2 diabetes into remission. And that can occur from a number of ways. So essentially, if you can lose sort of 10 or 15 kilograms, then you can put it into remission. Or there are studies show that using a low carbohydrate approach can also put type 2 diabetes into remission. So patients can get off their medications, their blood glucose can return to normal levels. And there's been some good work. I'm not sure if you're aware, but there's a Professor Roy Taylor in the UK who's done some excellent work and excellent research on putting type 2 diabetes into remission. Dr. David Unwin, the GP, who's done amazing work in the UK with putting his patients into remission using a low carbohydrate approach. So it doesn't have to be progressive, but obviously, but type 1 diabetes, if it's well managed and you can maintain normal blood glucose, then hopefully, you certainly, there's no doubt that you reduce your risk of long-term complications if you can keep your blood glucose levels within a healthy range. And that was shown in the DCCT trial. That was the big trial that confirmed that. But interestingly, in that trial, the interesting thing was that they had a group of patients on a sort of an intensive management of their blood glucose levels, but that group of patients actually put on more weight and they used more insulin because, of course, they didn't have a low carbohydrate arm in that trial. It was just a trial of intensive control versus less intensive control. Yeah.
It'd be fascinating, I think, to run that trial again.
Yeah.
It's not going to be cheap, but I'd be very, very interested in the results, but including the low carbohydrate dieters as well. I just, if you don't mind, Dr. Stapleton, let me just mention the DCCT trial. That's for anyone hasn't heard of it, Diabetes Control and Complications trial.
Yeah.
So that's, their result is the best we have so far to go by, because they have a very good chart on blood glucose levels, or actually HbA1c levels in particular, and they put them in color-coded optimal range, normal range. And I think I have it in my kitchen. I just keep it in my kitchen, and I try to aim to not the normal, but the optimal range to further reduce my risk of diabetes-related complications, because I'm afraid of those too. My family, a lot of people in my family, extended family, have type 2 diabetes.
Yes.
And as a type 1 diabetic, I can easily become insulin resistant if I just take unlimited amounts of insulin without care. So it's something that truly worries me.
Yeah, no, look, I think, it's interesting, isn't it? Like the modern diet, even if you've got a functioning pancreas with, normal beta cell mass, it's the Western diet that most people are eating, they can't tolerate it. So then, if you try and manage that diet with using exogenous insulin, so the insulin that we have to inject with type 1 diabetes, it's a disaster, to try and manage that Western diet, which is leading to, an explosion of chronic diseases that we're seeing, and obesity and type 2 diabetes. And then you combine that with exogenous insulin, it's a bad combination. And so, my diet is really very straightforward, but I really have just tried to return to the basics. Like I select a protein and I've varied proteins, fish, eggs, meat, and then I match that with a salad or vegetables. It's really quite a simple, straightforward approach. And I'm able to use a lower insulin dose to manage those meals. And I have no trouble I find that diet is very satisfying, and then I'm very rarely hungry and can fast for prolonged periods of time without any hunger, often skipping meals, not because I'm trying to or anything like that. I'm not hungry, so I don't eat that meal, and yeah, so I that's what I do essentially, and I've been able to maintain, I found it a lot easier to maintain a healthy weight than before. So, my weight probably sits around about 72, 73 kilos now. And I find it sort of fluctuates around that level. Like it might creep up a little bit to 74 and then it'll drift down again to 72. But I don't have any trouble maintaining a healthy weight. So I've just found it's the easiest approach for me. Mm-hmm. It makes my life easier. I'm not having to manage a roller coaster blood glucose levels. I have a nice flat trace, and then that calm, flat sort of trace allows me to do everything that I would do before. I surf and, I do sea kayaking and cycle my bike and, dinghy sail and all sorts of things. And I just find that by having that sort of stable blood glucose, it enables me to do all of those things.
Mm-hmm. My experience is similar too, whereas before I would fill my plate. Well, the first thing I would put in my plate would be the rice or the pasta. Yes. And then vegetables, maybe salad or some other cooked or roasted vegetables. And then maybe I was a vegetarian, so maybe an egg, if that, or cheese or yogurt. I was a vegetarian, not vegan.
Yes.
So it took a whole change of mindset for me. I am a meat eater now, no longer a vegetarian, and my blood sugar control is so much better. Now I prioritize the protein and fill the rest of my plate with low carbohydrate vegetables.
And that's...
And it doesn't mean that, I'm sure you can relate to it. It doesn't mean that we have no highs and lows. We're just running at this straight line all day long, every single day. No, you still have the highs and lows, but they're within range and they're not severe. Do you relate to that?
Yeah, absolutely. So I set my high sort of level on my CGM. I've got the Dexcom now, and I set that at 7.8. So I try to stay under 7.8. And 90% of the time I'm under 7.8. But sometimes I'll go, up to into the 8s and stuff. It's extremely rare for me to go over 10. Like it does happen, but it's very, very rare. So I really sit predominantly in that normal range. And the doses of insulin to correct are small. Like everything is small, essentially. Like everything happens slowly. So, if you're going low, because you don't have a lot of fast-acting insulin on board, it's a very slow drifting low. And so you'll notice it, like I've got the CGM on, obviously, which helps me. So I'll notice that I'm very slowly drifting. And I'm like, okay, I pretty much follow Dr. Bernstein's approach. So I'll use glucose tablets, and I know exactly how many glucose tablets will raise my blood glucose by 1 or 2 millimoles. So, I'm 2 grams of glucose just to sort of tap it up and get it back into a range that I'm happy with. And similarly, if I start to drift high, like it's a very slow sort of drift, and I sort of make up these sort of numbers, but if I start heading over 6.7, then I might just give a little dose of some correcting dose just to sort of drift it down again. So it all is very sort of slow corrections. Nothing's happening sort of dramatically fast with a double up arrows or down arrows. In fact, it's very rare that I would see even up or down arrows on my CGM trace. Sometimes that slopey angle, but mostly it's a flat angle and just sort of very slowly drifting, which makes it easy to correct.
Yeah, my management system is very similar to yours. I've set a very tight range for myself, but I don't look at the time that my range is 3.9 to 6. I'll put all the conversions on the screen for anyone who's using different measurements. It's a very tight range. But I don't mind those instances when I'm out of range. I mean, I don't mind them. It doesn't bother me because I know that that's an extremely tight range and perhaps even unrealistic. But at least it's something I try to aim for. As opposed to, running at 10 and 12 and even hitting 16 after a meal of pasta. I mean, in my carb eating days, that's what my blood sugars used to run so high, despite my efforts, that at a level of, 7, maybe even 6, I would start feeling hypoglycemic.
Yeah, that's right. Yes. And that's the thing, isn't it? That's what people find is that, if you run high all the time, then when you do start to run, even in a high normal range, you can have symptoms of hypoglycemia.
That's right.
But look.
No, go ahead.
No, sorry. No, you go ahead.
Oh, I was going to talk about the hypo severity, I guess. Right? I mean, it's very different. Whereas before I would feel hypoglycemic at 6 or even 5.5. Now I function because I'm so fat adapted. My body doesn't rely on glucose for energy. It just burns ketones for energy. And my brain has enough fuel pretty much the whole time. So I feel perfectly fine at a figure of 3.6. As long as I'm running straight at 3.6. I'm perfectly normal all day long at that figure.
Yes, exactly. No, that's right. I mean, I do, again, Bernstein sort of aims at 4.6. So I'll sort of tap it back up to get to that sort of number. But I agree with you. And it's interesting, so I will still obviously, because obviously one of the risks is hypoglycemic unawareness, people who don't sense it, but I will still, sense if I go low, but normally I will start to feel symptoms like in the low 3 range rather than, before that. But of course I'm monitoring it because I've got the glucose monitor on. I pretty much know where my numbers are all the time anyway. And there's a reason for that in that the ketones do provide, and I would have some, low level ketones all of the time, and they do provide some protection in terms of an alternative fuel for the brain, because the brain can partially run on ketones as well as glucose. And a lot of people don't understand that. A lot of people don't understand that ketones, cross the blood-brain barrier, and they are actually a fuel for the brain. It's actually why they're there. They're an alternative fuel for the brain as opposed to glucose. I don't aim, it's not like an aim that I have to have ketones, but when I test for them, I do have low levels of ketones, and I'm not worried about that. I've had them for 10 years. I'm well. My blood glucose are in normal range. I regard it, it's a healthy metabolic state to be in. It's just one of those metabolic states that your body uses in a low carbohydrate environment or during fasting.
So that's normal ketones in the context of nutritional ketosis. That's perfectly normal. I don't regularly test my ketones anymore.
No.
But having ketones on board in the context of a low carbohydrate diet is a completely different scenario from having ketones in the context of glucose burning, which actually is a risk of DKA for anyone who hasn't heard of it. Why don't we go through that, Dr. Stapleton?
Yeah, so interesting topic, isn't it? So basically in an extreme insulin deficiency, then you can get into a state where you're burning fat, and so your ketone levels go up, but also in that low insulin state, you've also got very high blood glucose levels, and you're unwell. So it's a very it's a very dangerous medical condition. You need to be in hospital, you need to be managed for it. You're very sick, and patients can die from diabetic ketoacidosis. And so that's why, the fear around ketones and diabetic ketoacidosis, and I understand that. And but this is very different. This is not. We're not unwell. We just have chosen a diet which is lower in carbohydrates, and because the diet's lower in carbohydrates, we're using, as well as glycogen stores, we're also using our fat as a fuel, and therefore we have some ketones as a result of that. But they're low-level ketones. They're still controlled by the exogenous insulin that we're giving ourselves. So because we're using insulin, we're keeping those ketone levels suppressed. We're not acidotic, so we're not in a state of diabetic ketoacidosis. It's nutritional ketosis. So the blood is not, the pH of the blood is neutral. It's not acid, essentially. And so that's the difference. And a lot of people, including doctors, don't understand that difference. And a lot of doctors as well don't understand that ketones are a fuel for the brain as well. So there's a really interesting study. I don't know if you're aware of it. There was a study done by a guy called Cahill in the US. I don't think you get ethics approval for it now, to be honest. He took 3 type 2 diabetic patients, and they put them on like a very sort of low calorie,
yes,
low carbohydrate diet. And they actually drove their ketone levels up to 6. So that was actually very high levels of nutritional ketosis. And then they put them on an insulin infusion. I don't know if you're aware of this study. So they put them on an insulin infusion, and they drove their blood glucose down, and they got down to 1 millimole of blood glucose, and the patients were asymptomatic. And at that point, they freaked out and they terminated the experiment, because they obviously didn't know how low they could go, and they didn't want to do any damage to the patients. I don't think you get ethics approval for it now. But that was interesting for me, because it showed me that, it shows you that the brain can function at lower blood glucose levels, provided you've got an alternative fuel on board, and ketones are an alternative fuel. And I have noticed that when I go low, because I still will occasionally go low, and I'm sort of talking, in that sort of, below 4 range, or, more trending down towards 3, I will feel symptoms of hypoglycemia, but I can still mentate. I can still get myself out of trouble. I will get symptoms, and I'll get, the shaking, and I'll feel a bit like, I know I'm not quite right. I might get some numbness around the lips, that sort of thing. And I'll go, okay, I'm running low, and then I can correct and get back into a safe range, and I can do that quickly. And I guess the way I describe it is, it feels like, like your computer can go into like a safe mode, where it doesn't have all of the functions, but it's still safe, and you can still do some things. And that's sort of what it feels like to me when I'm in this state. I'm still mentating normally. If you were chatting to me, we could still have a normal conversation. But I know that I've got some symptoms of hypoglycemia. I know that I've got to correct them and get back to a safe level. And so, in the 10 years that I've had diabetes, I've never had a situation where I've needed anyone's help to get me out of a hypo. I've been able always to correct it myself. So I do think that it does provide you some neural protection, and that there are some advantages to running, low levels of ketones, just as having a different fuel that your brain can access if your glucose is running low.
And if you are on a low carbohydrate diet, where your carbohydrates are coming from low carbohydrate vegetables, you are going to be, it just makes it, you are going to be in ketosis pretty much the whole time, even if it may be a low level of, you are always going to have a low level of ketones on board. What do you think?
Yeah, look, I used to, like you, I did used to test them just more out of, an interest and sort of knowing what was normal for me and trying to sort of determine what was normal low level. And, again, Dr. Bernstein doesn't aim for ketones or whatever. And so I'm sort of like him. It's not something I aim for, but when I have tested, I've had low levels. And so I used to test just to get a bit of an idea, and they might be 0.8 or they might be 1.1, so very low levels. But again, stressing, feeling well, not sick, normal blood glucose levels. So, it's all under those scenarios. It's not ignoring the ketones. It's just understanding the context of them, that why they're there. They're there not because I'm sick. They're there because of the diet that I've chosen. They're at a low controlled level because I've still got insulin on board. My blood glucose is still normal. Obviously if I was sick and my ketones started to rise, I'd be straight to hospital and getting that sorted out, because, that's a really important point to make. But it's not low levels in the context of feeling well and being normal is not something that I'm frightened of.
Two personal stories from me. During my 44 years with diabetes, I've had to go to hospital with DKA twice, but on both of those occasions, blood sugars were just unbelievably high. I probably didn't have enough insulin on board, and those were in my carb eating days, high carb days.
Yeah,
and since low carbohydrate diet for the past 7 years, I haven't had a single case of DKA. I just wanted to mention that. But also another anecdote, just actually a few days ago, I went to my routine checkup to my GP, and he did a urine test. And he said, oh, ketones, I think it was 2.8 or something. And, it's only an estimate because you have to interpret the colors. So, and he was all freaked out. And I said, well, yeah, they're expected to be there because I'm on the keto diet. And he was like alarmed and he didn't know anything about it. He said, but you're type 1 diabetic. It's not suitable for type 1. Keto is not suitable for type 1 diabetics. And I couldn't help myself. I said nonsense. And I recommended Dr. Bernstein's book. I think I offended him inadvertently, but I was just so shocked. What planet are they living in? I mean, what world? How can you be a GP and not be aware of at least the benefits of the keto diet for particularly type 1 diabetics?
Yeah, we're not taught it though. I don't think things have changed from when I went to medical school. Nutrition formed a very small part of our program. And we were basically taught, look, it's the food pyramid and it's calories in, calories out, and all this is pretty simple, and that it could not be further from the truth, and it's complete nonsense in my view. But look, most doctors I don't think have a particularly good understanding of nutrition at all, and that's medical practitioners or doctors as a group, they're still, a lot of doctors will suffer from the same metabolic conditions that the general community does. I don't think we're particularly well trained in nutrition. We're much more trained in sort of, I guess, medicating diseases or using, surgical treatments to treat conditions and diseases rather than nutrition as a tool, as a primary tool. Yeah.
And hopefully that will change in time, but it will take years, in my opinion.
Yeah, look, I hope so. I don't know. Yeah, I really don't know. I do think there have been some significant changes in the last 10 years, in that I guess what I've seen change in that time is that it's now being accepted that type 2 diabetes can be put into remission or reversed. It's the ADA in their position statement last year, they said that a low carbohydrate diet had the most evidence in terms of managing blood glucose levels. So that's a really positive step. Diabetes Australia put out a position statement a couple of years ago on low carbohydrate diets for people with type 1, and they didn't come out and wholeheartedly support them, but they said that if your patient chooses a low carbohydrate approach to manage their type 1 diabetes, then they should be supported in that decision and they should be given support. And that's really been, I mean, my position is that, you know, like I understand that for some people, they don't want to do what we're obviously doing, which is using a low carbohydrate approach. And I have no problem with that. If they don't want to use a low carbohydrate approach, then that's great. Then, you know, their medical team should train them to use insulin to the best of their ability. They can still focus on lots of other sort of health exercises and those sorts of things to try to manage their condition the best. But if I think, well, what I do think is that a low carbohydrate approach should be offered to patients with diabetes, and hopefully the medical team treating that patient with type 1 diabetes is knowledgeable enough about a low carbohydrate diet that they can assist them and that they can provide support for them. So that's really my, you know, that's really where I would like to see us get to that point where it's an option. It's like, you know, how do you want to manage your diabetes? You know, do you want to use multiple daily injections? Are you going to use a pump? Are you going to use closed loop? You know, there's all these sorts of exciting technologies. Okay, you know, how, you know, what nutritional approach are you going to use? You know, there's evidence that a low carbohydrate diet will assist you. You know, if you choose that approach, then, you know, we can provide you with expert advice on how to safely implement that approach, and we can support you in that approach. If you choose that you don't want to do that, that you want to go and use, you know, a standard diet, then we will assist you with that. And that's really where I'd like to see us get to, you know, just very much with the patient at the centre, or the person with diabetes at the centre of that decision-making process, and being offered all of the options and being provided with all of the support they need, rather than, as I had to do and probably you had to do, which is find it for ourselves and find support groups online and you know, predominantly online, I guess. That's where a lot of the support comes from, is peer support from people that we've found online, as well as obviously resources like Dr. Bernstein's book.
We mentioned our ranges, or our target ranges. I mean, you've set yours up to 7.8, the highest. My high is 6, and I don't mind that it's only the 50% of the time I stay within range, but that doesn't bother, don't look at that. So what are your thoughts on the default system? I mean, my Libre, I don't have the Dexcom, so I can't comment on that, but my Libre, Freestyle Libre, defaults to 10 being the normal range, and it shows everything between, I think, 4 and 10 as green. So the line goes green. Yeah. The graph shows up as green because it's the normal range. What do you think of the normal being defined between 4 and 10? And if you're 3.9, that's going to show up in red. Oh, danger. So what do you think?
Yeah, so that's interesting, isn't it? So the lab values for so if you send a blood test off, and you'll have lab values, right? So at least the labs in my home state, the reference range will be 3 to 7.8, because it's not a fasting, or it doesn't know whether you're fasting or if you've just had a meal. Okay, so that is interesting, isn't it? Because that is obviously what the lab has defined as the normal range, between 3 and 7.8. And I think that's probably right. Now, most people, if you know, Dr. Bernstein says 4.6 millimoles is really where you should be. And I think that's about right. My aims are a little bit different to yours, in that I like to be under 5.5 before a meal, and I don't like to go over 7.8. So I sort of accept a little bit of fluctuation post a meal. And I use those numbers, I guess, because given that 7.8 is the upper range for the, the lab that, when the blood test of, that is sort of an accepted upper range of normal. And that's, I guess, why I use those numbers. But I am aiming to be under 5.5 before a meal, and then we'll allow a little bit, but obviously hope not to go to that. But, again, I guess it's sort of better for my mental health if I feel that maybe having that broader range helps me, because for the most part, 90% of the time, or about over 90% of the time, I'm in that normal range. And so that's reassuring to me that, that I'm unlikely to suffer the complications down the track. And that's really what I'm trying to avoid. As also, that you obviously feel better when you're in that normal range, but also the long-term complications. Yeah. And I do think, I do see, I'm seeing a lot of work being done in the technology advances, and I do certainly see some great benefit with the closed loop technology that's coming, where, it's already available to people who do it yourself, but, the tech device companies are starting to integrate the CGMs with the pumps. And I can certainly see, in terms of just the mental workload of managing diabetes, that will, make it even easier. My personal view is that the low carbohydrate diet and exercise is still synergistic with those technologies, because, if you were to use that technology, but you were to eat like a standard Western high carbohydrate diet and be pumping massive amounts of insulin into you, I still think that the long term of that is, obesity, insulin resistance, type 2 diabetes, metabolic syndrome. So I still think that's a bad pathway in the longer term, but using that technology and then matching it with a low carbohydrate approach and also, exercise, to me is really the perfect combination in terms of making life easier, and staying in the normal range, but also making it easier for the tech to keep you in the normal range, because you're not providing these massive inputs that it has to try and counter. And again, I try and think of analogies for people to sort of describe how it is. And, it's a little bit like you're trying to steer a boat rather than a car, but, you're trying to make small adjustments and then keep on that pathway. If you're making big adjustments and then having to counter it with big adjustments, it's very easy to get that system unstable, and it's very hard then to get it back into stable. But if you're just making small adjustments all the time, it's much simpler for the whole system to work. And if it's sort of slow, small adjustments rather than these dramatic swings that you're having to counter. Yeah.
I agree. You have another analogy. I think it's a fridge analogy. I can't remember exactly. You might remember one of your talks.
Oh, well, I was talking about, that was really a talk about how that was more to do with, if you looked at the HbA1c gives you an average, but it doesn't actually tell you how you got to that average. So, for example, and it was interesting because I ran into one of my colleagues from medical school only last week, and he said, how's it going? Because he knows I have type 1 diabetes. And I said, my last HbA1c was 4.8. And he goes, you must be having, you're having a lot of hypos. And that's because, they're used to a trace that's sort of doing this up and down. And therefore, if the average is 4.8, then you must be having lots of hypos. What they don't understand is that if you've just got this very, as this shallow sort of thing, then obviously that allows you to safely lower that average and you're not having hypos. So that was the sort of analogy with the fridge, was really, saying that, well, I guess, it was saying that if you had like a fridge that was really fluctuating but had a low temperature, then that's not a good thing. You want it to be a sort of a constant temperature. And that's what allows you to sort of, having a flat trace allows you to safely lower the average. If you've got a really fluctuating trace and you try and lower the average, you're going to be having lots of hypos. And that's what most of your doctors will think. You know, if you've got a low HbA1c, they're like, well, you've got to be having lots of hypos, because they've only ever seen these massive peaks and trough on the trace. And so they don't understand that, no, flatten it off and you can safely lower it.
But yeah, I think I've seen people with maybe not 4.7% for their HbA1c, but relatively normal and healthy HbA1cs, but they are fluctuating horribly all day long. So they're having the highs and the lows. And yet, if you were to judge their health and their control by simply looking at the HbA1c, then you're really missing out on a lot of data. So this is why I love having my CGM.
Yeah, I think the CGMs are game changers. I really do. And I do think the next big game changer is the closed loop. I think that having that pump that's integrated with the CGM. And again, I'm not that at the moment. I'm still just using multiple daily injections, but I do see a time in the future, essentially when they get the tech to the point where it's easy, then I can see a point where, you know, something like that, it certainly might be something that I look at. But I would not alter from the low carbohydrate diet. Like that's a change for life for me. It's not like I would go to that and then go, oh, okay, great, I can eat, you know, go eat carbs. Like I've eaten this way for 10 years. I enjoy eating this way. It helps me manage my blood glucose and my type 1 diabetes, and I find it an enjoyable and satisfying way to eat. So I'm not altering the way I eat.
Dr. Stapleton, we're going to wrap this up, but your thoughts on, I mean, we're called the low carb and fasting. We covered low carb during our talk, but what are your thoughts on fasting? Skipping a meal? Can a type 1 diabetic skip a meal?
Yeah, look, I skip breakfast most mornings. It's probably not the meal you should skip, but I'm not hungry in the morning, so I skip breakfast, and mostly we'll eat at midday and then at dinner. You can absolutely skip a meal if you're not hungry, provided that, I guess the important bit there is that you've got your insulin doses right. You know, so obviously I'm on multiple daily injections. So as long as your basal insulin is dialed in correctly, then the whole idea of your basal insulin is that it should keep your blood glucose levels stable during a period of fasting. So as long as that's set at the right level, then you should just be able to fast essentially until you feel hungry, and then you eat. And that's exactly what I do, you know, like, and so some days I'll eat a bit more and some days I'll eat a bit less. If I feel hungry, if I feel hungry at breakfast, I'll eat breakfast. But if I'm not hungry at breakfast, I won't eat breakfast. You know, I go through till midday. Typically on the weekends, my first meal of the day will be sort of almost like a brunch, like it'll be, 10:30 or something like that. And then I'll have an earlier dinner, which actually then makes it easier. Because probably, if anything, the hardest part of my blood glucose management at the moment, I find, is when I'm asleep. It's easy to manage during the day, a little bit of glucose or maybe a correction dose or something like that. And I do get a delayed blood glucose rise from protein. So, I use, as per Dr. Bernstein, I use regular insulin to dose for protein. But sometimes, if I've had a big protein meal at night, then I will get, a delayed glucose rise overnight, and then I'll wake up with a higher blood glucose level than I'd like. And so I guess that is the bit that I find the hardest to manage still. But so on the weekends, I would often have, maybe a brunch and an earlier meal. And then I find that also helps with maintaining the blood glucose levels overnight. And I guess that overnight, a part of the equation is where I really see the closed loop would help. Because what I've seen from people who are using a closed loop with the blood glucose, with the CGM and then the pump that's dialed into that, is that they wake up at the right level every morning. Because it's very easy for that closed loop to actually manage the overnight blood glucose levels. Where the closed loop will struggle, and in fact my numbers are better than any of the data on closed loop anyway, and that's why I'm not trying at the moment. Where it struggles is with exercise and with meals. Particularly with a high carbohydrate meal, it's still going to have trouble managing that glucose excursion. But yeah, no, in answer to your question, I guess, getting back to fasting, I do fast, but it's very much based on how I'm feeling, if I'm hungry or not. And if I'm not hungry, I don't eat. And I have no hesitation in skipping a meal. I'm not worried. So one of the big things is that, they say with people about fasting is that because if you've been eating a high carbohydrate diet, when you fast for, you feel this hunger, and it's a very unpleasant experience to be hungry. And sometimes people, and I used to too, by the way, you can actually experience symptoms of hypoglycemia, which is again an unpleasant, shaking and I need to eat and those sorts of things. And that's so unpleasant for people that they will absolutely not skip a meal and, will eat when they're not hungry because they fear a future, episode of this hunger and this hypoglycemic episode. But when you're on a nutritionally dense, whole food, sort of low carbohydrate type diet, then you really don't get those sort of hunger or urgent need to eat that you did before. It's more of a, I'm a bit hungry, I could probably eat now type of experience. And therefore, because it's not that unpleasant, you lose that fear of this future unpleasantness. So you never feel like you've got to eat in advance of hunger. Like I never feel, I've got to eat now, because if I don't eat now in 2 hours' time, I'll be really hungry. That would be terrible. And yet other people I know, and I used to be like that, I guess, other people are like that, aren't they? And that's why they eat when they're not hungry. And I'm trying to sort of really listen to my body and listen to how I feel. And if I don't feel hungry, then I'm comfortable not eating. And then I'll eat when I'm hungry. And so sometimes, you go on.
As long as your insulin dose is correct, your basal is correct, you shouldn't really drop too low if you're not eating. If you're not eating, you're not taking your bolus insulin.
Exactly.
And it shouldn't have any negative impact as long as your basal is right.
Exactly. And so, I typically will have lunch at 12:30 at work. That's when we have our sort of lunch break. But, sometimes I get busy and I can't take it then. And, sometimes it'll go through till 3 or 4 in the afternoon. And then that's just not often, but sometimes. And then I might eat lunch then and then not have dinner. And I have one meal for that day, so it's very much based on how I feel. It's not. It doesn't have to be too regimented, but again, you've got to have your basal dose right to be able to do that. Yeah, if your basal dose is too high and you're drifting low, then you'll be forced to eat or at least to correct that low, because your basal dose is too high. And I think a lot of people have probably a higher basal dose maybe than they should, because they're used to sort of eating all the time. So that basal dose that they're on is actually correcting for their snacking and other things, rather than being a true basal dose.
Mm-hmm. Yeah, I run a private Facebook group for type 1s who run keto, but who also do fasting, and not only intermittent fasting. Some of us do extended fast every now and again too.
Yes.
And we share experiences, and the peer support you were talking about earlier on is so important, because no one else out there is supporting us, no professional from our healthcare systems supporting us. So we end up supporting each other. And it comes down to two things: having a CGM, so you're constantly and closely monitoring your blood sugars, and having dextrose glucose tabs next to you at all times, like I do. I carry it in my pocket at all times. And also being confident adjusting your insulin. Yes,
that's right. Yeah, I haven't done any extended fasting. I probably do, 18-hour fast would really be the longest I've sort of gone, that sort of yeah, that would be my level. But yeah, like I certainly have no hesitation doing that. And I know Dr. Bernstein's more regimented than that. You know, he has 6 grams for breakfast, 12 at lunch, and 12 at dinner. And I guess my approach is heavily influenced by his approach, but obviously it's not exactly everything that he does. I eat tomatoes, for example, whereas I know he doesn't. So, you know, it's a few things that are different.
Yeah, mine is, I mean, I follow his protocol, but not to the T. So I have to make it obviously relatable to my preferences and my lifestyle too. I don't, you mentioned the R insulin, regular insulin. It's very uncommon here for type 1 diabetics to access, I don't know in Australia, to access through our healthcare system, R insulin. But what I do instead is I use my, well, obviously I have a pump. So I'm using one quick acting insulin, NovaRapid. So in my pump, what I do is pretty much to replicate what an R insulin would do for protein that would have a delayed effect. I would use the extended bolus. So that means my bolus, I'm not taking the bolus in one go all at once. I'm having it over, I don't know, 6 hours, maybe over 5 hours, small doses of bolus to cover the protein. But I also avoid having meals late at night because that delayed effect would happen when I'm sleeping. And
that's right.
And that's
exactly. And it's all trial and error, isn't it? And that's what you discover. And that's really the benefit of the CGM, isn't it? Because you're learning the whole time from the CGM. You have this meal and then you see what happens. And so, you know, you get data every 5 minutes and every meal gives you data, you know, so, you know, you're 7 years down the track with low carb, you know, I'm 10 years down the track from low carb. So, you know, we've now conducted, you know, thousands and thousands of experiments on ourselves by trialing a different meal with a different insulin dose and seeing the result of that, and then using that experience to guide us. And that's why I think CGMs are such a powerful tool. In fact, I'll give you an interesting anecdote. One of my friends is a pediatrician, and she manages patients with type 1 diabetes. And CGMs are now subsidised in Australia, and I know they are in the UK. Lots of countries have seen the benefits of them, and so that's been a really positive thing. And she said that what happened when they introduced the CGMs was that they had like at least a cohort of patients who naturally started lowering their carbohydrate doses, because, you know, parents would see, they'd say, well, when I feed them this, it spikes like this, and then, you know, but when I feed them that, you know, like if they have eggs for breakfast, then it's much easier to maintain. And so, you know, they noticed this trend that patients, once they could see the data, were naturally sort of modifying their carbohydrate intake lower based on the results of their CGM. And the other thing that she told me, again, sort of an interesting anecdote, I guess, is that they can tell, like they could tell by the CGM traces who was low carbing. Because, you know, a lot of patients, unfortunately, because a lot of patients aren't supported by their medical teams choosing a low carbohydrate approach and supported in that decision, you know, they sort of do it surreptitiously, don't they? Like they discover it and they implement it and they see the results and they keep doing it, and they, you know, they might feel that they can't tell their doctors, but she said they can tell by the CGM traces. So she's like, yeah, we can tell, like they're clearly low carbing by that CGM trace. You know, so it's interesting. You know, the doctors must be seeing. There's enough of us out there now that are doing this, that I'm sure a lot of the treating teams are becoming at least more comfortable and a little bit more experienced. Whereas I guess 10 years ago, it was you know, not many people knew about it, did they? I mean, 7 years ago for you, you know, you were diagnosed 44 years ago, so, you know, 37 years of a high carbohydrate approach, and then 7 years of discovering a low carb and implementing it. I don't know your story, but I'm assuming you discovered it and you tried it and it worked and you kept doing it, and it wasn't because your medical team helped you with it. That's what I'm assuming.
No, I received, in fact, I was dismissed when I first mentioned I was trying a low carb diet because my HbA1c had come down, and my diabetes consultant questioned what happened. What did I do? Finally, my HbA1c was coming down. And then she wasn't pleased when I said a low carbohydrate diet. So then I decided not to mention it again. So doing it alone.
And that experience is common. And I think the thing that I find, well, what disappoints me in my medical colleagues, I'm going to be honest with you, is just the lack of intellectual curiosity. When they see this, they, instead of going, wow, tell me about what did you do? Tell me more about this. Because it doesn't fit with their medical training, they dismiss it, or they get angry about it, or they get upset with their patients. And I think, I think that's really disappointing. And I've challenged some of them. I've had debates with them over it, and I've said, look, you go get, bring me the evidence that your approach is the correct approach, because I've looked for it and I can't find it, right? So if you can find it, then you show it to me, but don't tell me that that your approach is correct if you can't bring me the evidence. And the evidence doesn't exist. And again, so I think it must be about 7 or 8 years ago, I did an interview on ABC Radio. I don't know if you've heard that interview. You can search it up. It was Norman Swan. Anyway, so I did an interview, and if you look up, I think the Health Report, Dr. Norman Swan, Troy Stapleton, you'll find it. It's about a 12-minute interview that I did. And this was probably about 2 years post-diagnosis. So ABC have a thing called the Health Report. Norman Swan is a journalist. He was a doctor who hosts it. And they had done an episode talking about the increasing rates of amputations with diabetes. And I don't know if there's a guy down in Melbourne called Ron Rabb who's been low carb. He knows Bernstein, and he's been low carb for a long time. He's had type 1 diabetes for 60 years. He's been low carb for 20 or 30 of those, I think, a long time anyway. And I had been in contact with him. Anyway, he said, look, I had met Norman Swan at different medical events. And he said, look, Norman, why don't you contact him? So I did. I sent him an email, and he said, oh, why don't you come on my show? What I didn't, so he interviewed me, and we talked about using a low carbohydrate diet for type 1 diabetes. What I didn't know was that the following week, Norman had planned to have the head of endocrinology for Queensland, essentially, I guess, to rebut what I'd said, And what was interesting to me was that he couldn't rebut what I said. And the following week, he was like, oh, well, yeah, I guess it would work, but Troy's, he's, not many people are like him, they're not motivated like him, which, I get really cross about that, actually, because, that's very paternalistic from the medical profession as well. And in fact, you don't get to choose what's too hard for me as a doctor. Like, if you're my treating doctor, you don't get to choose what's too hard for me. I want to know all the options, okay? Because I've done a lot of things that are difficult. Getting into medical school was difficult. Passing medical school was difficult. Getting into specialty training was difficult. I've actually got a bit of a history of being able to achieve difficult things. So you, as my treating doctor, don't get to decide that a dietary change is too hard for me. That's not something that you get. Your role, if you're treating, the medical team treating a patient, their role is to give the patient the evidence and the options available to them, and to support them. That's what I think. And that's really what I'm advocating for, is just that this is an approach that a lot of people find really helpful, and therefore it should be one of the options that are offered to patients, and patients should be supported if they choose that approach.
Yeah, I share your sentiments, and that's why I'm doing what I do. Every single day I receive emails and we have WhatsApp calls with other type 1s because they're lost, they're confused, they're alone. And if I don't tell them, hey, you can do this. Do you have a CGM? Yes. Do you have glucose tablets? Yes. Can you adjust your insulin dose? Yes. Okay, let's do it together. I'll bring in other people so, we get group ideas as well. It doesn't have to be like this. It doesn't have to be like this. We don't have to be alone in this journey. But you mentioned a lack of intellectual curiosity. And that's interesting because, again, a few days ago when I went for my routine checkup at my GP's, he dismissed the keto diet. He said it's not suitable for type 1 diabetics. And he actually said that he's verified it with a local endocrinologist, and the conclusion was that keto diet is not suitable. And when I started citing Dr. Bernstein and other research papers, he said, oh, no more research. To me, it's good that you are, a researcher, but he said, no, don't share any more of that, because sometimes it can have a mental health impact on you. And he actually recommended, he put it in his recommendations, he typed it up, it's on the system, that I would benefit from some calming apps on my mobile phone to dispel my worries and concerns about certain things. It's just I have never felt as insulted as I did a few days ago. It was a nightmare experience for me. And I told all my family members, if I lived in the US, I would fire this doctor. But, because we're part of the healthcare system, the national healthcare system, I don't have the option of changing him, or I'm allocated one GP at one clinic based on where I live. I'm sure it's a similar system in Australia. I cannot switch him, I cannot change him.
It's different here. We're sort of like a balance between the US and the UK, I guess. So we've got like a private system and a public system. So we can choose our private medical practitioners, and then we've got free public health care as well. So no, it is, in Australia, you could just choose another practitioner. And I guess one of the things we're lucky about is that, there are a number of doctors who are now supporting a low carbohydrate approach. So you can find a doctor who will support you here. And similarly, there are now, dietitians who will support a low carbohydrate approach. And so what I find, if people contact me, like I'm very careful about, like, I don't provide individual medical advice to people. I say, look, this is what I do, but I'm not giving you individual medical advice. Mm-hmm. But I am comfortable at pointing people in the direction of people who can help them. So I will point people in the direction of registered medical practitioners and registered dietitians, but who are comfortable supporting patients with type 1 diabetes who choose a low carbohydrate approach. So I've got a number of people, and I say, contact this person and they'll look after you, and that's what they do. Yeah, so we're lucky here, I guess, that we've got that option.
Yeah. Unfortunately, in Britain, we don't have that option. So we're just allocated one diabetes consultant and one GP. And if they don't understand what you're doing, you're alone.
Yeah. So the Australian Diabetes Association, the position statement for low carbohydrate approach for type 1 diabetes, you should look that up, because maybe you should provide that to if they listen to for the colonials from the Antipodes. I don't know whether they'll ignore us, but they basically said that if your patient chooses it, you should support them in that approach. And I was really happy to see that. So they didn't come out and say, there's not a trial. There's no, let's be honest, there's no trial out there that's showing that our approach is a superior approach. We're basing we both clearly believe that it's a superior approach, and that's because our experience of it has been that it lowers and stabilizes our blood glucose. It lowers and stabilizes our blood glucose at a lower insulin dose. It allows us to participate in all of the things that we enjoy in life and exercise, you know, and all of those things in a safe way. So, you know, we obviously think that this is the correct approach, but there's no randomized controlled trial showing with long-term data and with, you know, hard endpoints showing that this approach is the best approach. Because if there were, then we wouldn't even be having this debate, you know, like it would be clear cut. The problem is, of course, that, you know, insulin was discovered 100 years ago and no one has done that trial. So we don't have the opportunity to wait for the medical profession to run that clinical trial. So we have to base our decision to follow this approach based on surrogate markers, so short-term surrogate markers such as blood glucose levels, HbA1c, you know, time in range, glycemic variability, those sorts of measures, which are all surrogate measures, to say that we think this is a superior approach because, at least for us as individuals, we get these better outcomes by following a low carbohydrate approach.
Well, on that note, I think we can wrap this conversation up. It's been wonderful having you share your thoughts and insights with us today. I'm sure a lot of my audience are type 1 diabetics, so they will appreciate this discussion. Thank you so much, Dr. Stapleton. Have a good evening in Australia.
Thank you. Thank you, Nayiri. Lovely meeting you.